Hi, Joyce O'Shaughnessy here, breast medical oncologist from Baylor University Medical Center, Texas Oncology, and the Sarah Cannon Research Institute in Dallas, Texas. And it's a pleasure to walk you through the poster, the in-depth safety analysis on the EMBER-3 clinical trial, which is a very important trial because we hope it'll lead to the FDA approval of both Imlunestrant, a novel oral SERD, as well as the combination of Imlunestrant plus abemaciclib in patients who've had a prior CDK4/6 inhibitor. That's where these new agents will be of particular benefit to patients. So very, very important, of course, to look at the safety and make sure that it's going to be feasible for patients to take the medication and get the benefit that we can see from the clinical trial efficacy data. So basically, EMBER-3 is a trial here. You can see the study schema here of 874 patients with hormone receptor positive, HER2 negative metastatic breast cancer. And these patients they've had adjuvant endocrine therapy, and they were recurring on adjuvant endocrine therapy or within a year of finishing their adjuvant endocrine therapy. And they could have had a CDK4/6 inhibitor or not in the curative setting, or they were progressing on their first line AI in the metastatic setting with or without a CDK4/6 inhibitor, but they were otherwise untreated for their advanced breast cancer. And it was a three-way randomization to, in the middle, the standard of care endocrine therapy, which was fulvestrant or exemestane, so a single-agent endocrine therapy, versus the novel oral SERD, Imlunestrant, versus Imlunestrant with abemaciclib. So that was the study schema, and for patients, about 70% of patients or so, they had a prior CDK4/6 inhibitor. So this was looking at a second CDK4/6 inhibitor for those patients, which was an important efficacy analysis where the Imlunestrant and abemaciclib, after progression on AI plus a CDK4/6 inhibitor, was indeed a very active combination with a 9.2-month median PFS. And if they had a ESR1 mutation, it was 11.2 or 11.3 month median PFS with Imlunestrant and abemaciclib after progression on a first CDK4/6 inhibitor in those with an ESR1 mutation. So very good results. The overall primary outcome analysis we can see in the background here, where we see improved progression-free survival comparing standard endocrine therapy to Imlunestrant in the ESR1 mutant population, 3.8 months median PFS with the standard endocrine therapy versus 5.5 months with Imlunestrant of the hazard ratio of 0.62, and we see that's highly significant, the p-value 0.001. And then comparing Imlunestrant alone with or without the abemaciclib in all-comer patients, it was 9.4 months median PFS versus 5.5 months with Imlunestrant alone, so the combination 9.4 months versus 5.5 months, and that was regardless of ESR1 mutation status. That did not make any difference, and regardless of prior CDK4/6 exposure. So Imlunestrant is well tolerated. We'll go through this in detail, but there's fatigue, diarrhea, and nausea. They tend to tachyphylax over time. They tend to go away. Then in the combination arm, as we'd expect, mostly driven by abemaciclib, toxicity, diarrhea, nausea, and some modest neutropenia. But we'll walk through the data here. So we can see here, if we look at diarrhea, which was the most important toxicity of the combination. So we look over here. Well, first of all, we can see with Imlunestrant alone, any grade diarrhea, 21%, versus just standard endocrine therapy, which doesn't really cause diarrhea. So just a background rate of diarrhea of 12%. And then with the combination, we do see a high rate, which we see with abemaciclib. It's usually about 80%. So that's really driven by the Imlunestrant. But grade 3 is very low. It's just 8%. Grade 1 to 50 and 28%. So diarrhea definitely is a feature. The good thing is that we've become very adept and used to managing diarrhea with the abemaciclib because a dose reduction makes a big difference, as does dietary, eating a bland diet and using loperamide, which is Imodium. So diarrhea is the main toxicity. 68% of patients did use an antidiarrheal medication with Imlunestrant and abemaciclib versus 10% and 7%. So not really a lot of difference there. And so the time to onset, the median time to onset was about 5 days here with the combination, about 30 days with the imlunestrant. It's really very minor with imlunestrant here. We can see just a little bit of grade 1 diarrhea, not very much different, again, than the control arm. Likewise, we can look at nausea here. Very minimal difference, maybe a little bit more grade 1 nausea with the imlunestrant compared to standard of care, but really very minor. We do see half of the patients having some nausea with the combination of imlunestrant and abemaciclib, but we're used to that again. It gets better over time. We know that very well. 21% of patients did require a antiemetic regimen, a nausea medicine, and 10% for imlunestrant alone versus standard. So again, we really can't say there's any difference there at all with the single agent imlunestrant versus the standard of care. Fatigue, again, 13% with standard, 23% with imlunestrant alone, 39% with imlunestrant and abemaciclib. And the percentage of patients that dose interrupted or discontinued was very, very low. We can see less than 1% of patients discontinued their medication of the combination because of the fatigue. And if we go up here as well to the diarrhea, which was the most important of the toxicities, we see discontinuation rates of less than 1% again, because it just shows it's manageable with dose reduction, dose interruption, dose reduction. It is indeed manageable. Now, a modest elevation of transaminases is part of the abemaciclib treatment, but again, we see that 2% of patients did discontinue because of LFTs, but it was mostly very manageable with interruption and with dose reduction. But in terms of grade 3, only 5% of patients had grade 3 transaminitis with the combination of imlunestrant and abemaciclib. It's fully reversible with holding the medication, and then you can reduce the dose. So there's toxicity there, but it's very manageable. When you see that hardly any patient stops their regimen because of toxicity, you know it's quite manageable. And this basically now looks at the toxicity by age. So which of the toxicities is more prevalent in those women 65 years of age or older? And we don't see a big difference. There's a little bit more nausea here with the over 65-year-old population, but not really. It's not really an age-dependent phenomenon. And then if we want to look a little bit more closely here at discontinuations here and dose adjustments, we did see that in the imlunestrant abemaciclib combination, that 61% of patients had an interruption or a dose reduction, and 39% had a dose reduction. It's interesting because in the adjuvant trial of abemaciclib, which was 2 years of abemaciclib to improve the cure rate, which it did, 43% of women did have a dose reduction. So here we're seeing a similar number of about 39%, but it makes a big difference. It allows patients to stay on treatment. So, and then again, with regard to single agent imlunestrant, dose discontinuations due to adverse events was indeed very low, just 4%. And you know, the frequency of discontinuations were low. In the imlunestrant abemaciclib, most dose adjustment occurred in the first few months of treatment. And again, there's really just not a lot of difference between the combination of imlunestrant and abema compared to what we already know about the abemaciclib. Other adverse events of interest, some neutropenia with the imlunestrant abemaciclib, 20% grade 3 or higher. Again, we see that with abemaciclib. ILD rates, none in terms of serious, less than 1% of a serious thrombotic event. 3% of patients having any thrombotic events. And what you don't see is bradycardia, photopsia, some of the toxicities you can see with other of the oral SERDs, nor do you see really dyslipidemia because lipid modifying agents were similar between the arms of imlunestrant and standard of care. So that's also a toxicity of some of the oral SERDs is elevation of the lipids, and that's not being seen here as well. And so this just basically gives us a visual here of dose interruptions by cycle and dose reductions by cycle, and is always the case with abemaciclib and most of our agents in general. It's the first few months where we're doing that adjustment for patients. The Imlunestrant really didn't need any, there wasn't any dose adjustments there. It was basically the arm C, which was Imlunestrant and the abemaciclib, and we're just seeing some early, the first couple of cycles, we're seeing some dose adjustments. So the bottom line is that this is a combination, the Imlunestrant and abemaciclib, that we would like to have in practice because we need combinations of a targeted therapy with an oral SERD. We have elacestrant, which is an effective agent, but it's a single agent, and so we utilize it successfully for endocrine therapy sensitive breast cancers, but we don't have an approved combination. That's why we would really like to see this doublet of Imlunestrant and abemaciclib approved so we can use it in practice. And these data here show that with our standard management of toxicities, as we do already with abemaciclib, that it's very feasible for patients to be able to take this important doublet. So we hope for regulatory approval before long.